How about yourself?
2.
Where are they?
I have a 32-year-old just got engaged.
Yeah.
Married
Wow.
next April.
Wow.
26-year-old. Was down in NBC.
2 girls?
No, 2 boys.
2 boys.
Josh and Jason.
I have Josh and Jacob.
Do you?
And a Laura.
Good evening. Welcome to Healthy Frontiers. I'm Dr. Bizzoni, and our topic for tonight is hip pain and knee pain. My special guest, actually, is Dr. Ira Kireshenbaum. Dr. Kireshenbaum has been here in White Plains for over 17 years. And I'm going to ask him to just tell us a little bit about himself, about his practice, and then we're going to get into answering some of your questions about hip pain and knee pain. So welcome, Dr. Kireshenbaum.
Thank you, Dr. Bizzoni.
Okay.
I want to thank you for inviting me here. I've been in White Plains and White Plains Hospital since 1990.
Okay.
Originally, I trained at Montefiore Medical Center, Albert Einstein College of Medicine,
Right.
where I did my orthopedics there after my medical school. Following that, I went to Pennsylvania Hospital and Thomas Jefferson University in Philadelphia, where I did a hip and knee replacement fellowship.
Okay.
And that was at the Rothman Institute. We did approximately 3,000 joint replacements that year, which is a lot of experience in more than one person.
Yes,
And,
all right. I want to make sure.
More than one person. And after that, I came to White Plains and was also at the Hospital for Joint Diseases in Manhattan while I was also in White Plains.
Right.
Then I worked as a chief of joint replacement at Kaiser Permanente from 90 to 95, and then was in a large orthopedic group. And at the same time, I was in Manhattan at Lenox Hill, and the practice of Dr. Chitranjan Ranawat, who was my associate from 98 to 2002, while I was also still at White Plains Hospital.
Right.
So I never left White Plains Hospital, and starting in 2000, I opened up my own joint replacement institute here in White Plains on Westchester Avenue, and we do quite a lot of minimally invasive and modern hip and knee replacement procedures.
Great.
And that sort of, I guess, summarizes where I've been the last 17 years.
It's quite a bio. It's great. Very
Yeah.
impressive. Patients will come to my office with back pain at times.
Yeah.
But, there's many reasons why people will have back pain. Why don't you talk to me and talk to the audience a little bit about other reasons why people get back pain?
Sure. It's very common that a patient comes to me with back pain.
Right.
And if they've gone to a back specialist like yourself, I'm fairly confident the back has been worked up.
Correct.
So right off the bat, I'm beginning to look for other sources.
Okay.
Sometimes someone comes to me having not gone to a back specialist, and I'll either refer them to someone like yourself or a neurologist, depending upon the medical condition. But I'll have to look at both the back and other parts of the body.
Okay.
Very commonly, when people complain about back pain, one of the first things I ask them is, what do you mean by the back? And I ask them actually physically to point.
Yes.
Because the back to one person, the back to another person. Sometimes I actually point to the hip.
Right.
Sometimes I point to the groin. Sometimes they point to the left part of their ear or something.
I know. Oftentimes people say, well, I have hip pain. They always go here.
Right. And so I always mean,
what
do you mean by the back?
Right.
And sometimes even I ask them, touch me. I'll turn around. I'll say, so I know what they're talking about.
Sure.
When it's in the lower back or it's in the front, like sometimes I'll say, it's in the back, but it kind of goes to the groin.
Yes.
Then I start getting suspicious of possible hip pain being the cause of the back pain.
Understand.
And the back pain is not truly back pain. So it's very common that a hip arthritis or a lack of motion of the hip will put pressure on the back and give them back pain when in reality they're not even able to move their hip at all. So not all back pain is back pain, and sometimes it's hip pain.
Okay.
Interesting enough, sometimes it's completely the other way around. I'll get someone comes to me with knee pain.
Yes.
Their knee examination is normal, and it turns out it's a primary back problem, like a herniated disc at a certain level in the spine where the nerve goes to the knee or to the hip.
Yes.
They'll complain of hip or knee pain, and in reality, they're back pain, and they need some type of spinal therapy or spinal treatment.
Yes.
And it's more often the other way, but they're all connected.
Okay. That's great. Tell me some of the symptoms if a patient has hip arthritis. What are they going to present with?
Well, the first thing they're going to complain about is pain on motion.
Okay.
It's unlike hypertension or diabetes where you can have and not know it.
Right.
We like to say the orthopedic patient knows he or she is sick.
Understood.
It's pain, frequently pain at rest at night, pain when they're walking up and down steps. The pain is usually in the hip. It's always isolated to the groin. Because actually, when people also complain about hip pain, they say to me, they hip and they point to the outside, which is really the pelvis.
Yes. Okay.
Or maybe the sacroiliac joint.
Right.
But for me, the hip is in the groin because that's where the joint is.
Understand.
So when they point to the groin, almost always it's a hip arthritis.
Hip. Right.
Sometimes it's also age-related. A
Right.
23-year-old is unlikely to have a hip arthritis.
Right.
But we see arthritis in patients as young as 40, 45 to as old as 90. And the symptoms are usually pain on motion. In knees, it's pain up and down steps.
How about when you first wake up in the morning, the patient goes, oh, until I get moving, doc, my back.
Yep. It's very common to have morning stiffness.
Okay.
I find it more in the knee than the hip.
Yes.
But that's probably because the knee requires us to move more.
Right.
In other words, when we sit in a chair, we bend our knee to 90 degrees.
Right.
When we walk, we don't really move our hip as much.
I understand.
But the morning stiffness is also a very big sign.
Okay, good. And you do many hip replacements. Talk to me about hip replacement. How it can relieve pain in the hip, please? First, before we do that, why don't we do this? Why don't we just explain what the hip looks like?
Okay.
So we see a normal hip joint, and then we'll talk about the surgery.
Well, all joints are two bones that come together and are separated by a cushion cartilage surface.
Okay.
Or whether that's a knee joint, a shoulder joint, or a hip joint. The hip joint is what is referred to as a ball and socket joint. Now, what I have here is a hip replacement model, but it shows very much the same thing. And I will take this apart.
Right.
And I'll show this part is the pelvic part. So this would be on my pelvis.
Right.
And there is a ball here.
Yes.
Now, this has a replacement in it, but the ball is the same. This acrylic would be the femur or the thigh bone, and that communicates with the socket for a ball and socket joint.
Right.
When you get arthritis, the problem is at this connection. Arthritis is not a disease of the bone. It's a disease of the surface that's rubbing together.
Okay.
That cartilage cushion wears away from many causes.
Right.
One of the most common causes of it wearing away is degeneration over time. But sometimes you can get arthritis from an accident, a motor vehicle accident, or an accident at work.
Yes.
You might have fell from a scaffold or a forklift injury or something of that nature.
And that'll speed up that arthritic change for sure.
Oh, absolutely. Even in a case of underlying arthritis, sometimes an accident stimulates it to advance at a higher rate.
Right.
Sometimes you also get arthritis from infection, or you can get arthritis from other diseases called rheumatoid arthritis, where the arthritis affects the whole body and then secondarily invades the joint.
How frequent is that for the hip joint, say, to get invaded by a rheumatoid situation throughout the body?
Rheumatoid is very rare in comparison to what is called osteoarthritis.
Why don't you explain to the audience the difference, please?
An osteoarthritis is an arthritis that is what we would refer to simply as a wear and tear over time. Now, how does that happen? Mostly it's genetic. Just like some of us get some gray hair, some of us lose some hair, some of us are tall, some of us are short. A lot of this is in our genes. And in a sense, much of arthritis is probably timed how long your joint will last. Maybe I have people come in and says, oh, I have arthritis because I was a football player. And I'll show you 500 football players who never get arthritis. So it's the osteo is the wear and tear over time.
Understand.
Rheumatoid is an actual disease that where the body reacts against itself. And we see rheumatoid arthritis in a very small number of cases in comparison to osteo. Maybe 1 in versus 100. You'll have 100 osteo. It may not be exactly the percentage, but it's relatively more uncommon. In the end, though, interestingly enough, once the joint is destroyed, it's the same treatment. A total hip replacement or a hip resurfacing procedure, one of the two, and we'll talk more about those differences, would give you a 99.5% cure rate from your arthritis, which is remarkable. So the source of the arthritis is less important.
Right.
It's interesting how it's the same treatment for both.
For both. Great. Talk to me about the advances in hip replacement today. What would you do in a surgical approach?
Sure.
Please.
Well, it's very interesting. Just to give you a little bit about the history of hip replacement. People think it might have been around for hundreds of years. Actually, the first hip replacement in the United States was done by one of my former partners in 1966.
Wow,
that's not ancient. That's not ancient history.
No, it isn't.
A little bit before the Grateful Dead, a little bit after the Beatles.
There you go. Right, there you go.
But it's not ancient history.
Right.
There was some precursor, meaning some early hip replacements in the 50s that all failed. But the genius of hip replacement was a surgeon from England whose name is John Charnley. And Charnley developed the first hip in the early 60s. The first one in the United States, as I said, was done in New York in 1966. There's been, interesting enough, the great advances from this genius in England.
Yes.
Well, let's say he brought us 85% there. In the last 50 years, we have improved significantly, but probably only 15% from his amazing advances.
Wow.
But those advances have been significant. Sure. What happens is in a hip replacement, we take a titanium or some type of metal stem, put it down the center of the canal, put a ball on top. And then we, on the opposite side, we put a shell and then a liner. And that is really what Charnley originally developed. And when you put it together, it moves freely with no pain. Now, what has happened in the last 50 years? Well, there were what I call three groups of advances. When Charnley first developed his hips, this stem was made out of a stainless steel. And a certain number were breaking. So I guess the first generation was, how are we going to stop the metal from breaking?
Sure.
And that was solved probably in the 70s, early 80s. We're using now titanium or titanium mixes, which are absolutely incredibly strong.
And no rejection by the body for this titanium. The body accepts that very readily.
Yeah, it's a great question. And we learned that answer, interesting enough, from the dental world. The oral surgeons were the first to use titanium implants in the mouth. And all that years of research in oral surgery was then applied into orthopedics. So we see all the fields of medicine contribute and give to each other back and forth.
Accept, take the best, use it for patient's benefit.
Yeah, absolutely right. And we learned that from the dental world, where the next generation, Charnley originally cemented these stems in place with a special type of cement glue, which has a fancy medical name, methyl methacrylate.
Okay.
We know it differently in the world.
It's
Lucite.
Lucite. We learned that a lot easier.
Lucite is methyl methacrylate.
Okay.
And Charnley decided to use it because you were able to mix it on the field, and 10 minutes later it hardened.
Great.
We found, though, after a certain number of years, the cement loosened, or you'd get loosening of the stem. Then came the advances we learned from the oral surgeons, where we used roughened surfaces of titanium where the bone grows into it, and like billions of barnacles, and attaches firmly. So generation change 2 from Charnley was, now that we've solved the metal not breaking, now we're solving the metal attaching to the bone.
Great.
The last, that was a great advance. The final frontier, which we're on right now, or what we feel is the final frontier until the next frontier comes through, was how do you prevent the plastic liner, which was on the other side here, from wearing out? Because it wears out at about 10 to 18 years, depending upon how much activity. Now, if you're 80 and it lasts until you're 98,
home free.
I'll take it. I'll take it, But if you're 50 and you're 68, it's no bargain to have to do what's called a revision or a second hip replacement.
And at 68.
And that is terrible, because then maybe at 78 you'll need a third. So we are now in the generation of new bearing surfaces. I think the finest one that's available happens to be a ceramic on ceramic bearing surface. I'll show you what that looks like. Instead of having a plastic, the inner is made out of a special type of ceramic, and the ball is made out of a ceramic. Now, when we think of ceramics, we think of camp and clay and things that could break.
Sure.
That's not exactly what medical ceramics are. Medical ceramics are actually a metal, aluminum oxide, and are extremely hard. Years ago, 20, 30 years ago, ceramics used to crack because they were so brittle. But the company that makes it internationally has really perfected the science of ceramics to take away that problem. So a ceramic on ceramic bearing we originally started experimenting in 1997. Again, not ancient history. Was approved by the FDA in February 2003. Okay.
Not that long ago.
Not that long ago.
No.
And this is the exclusive hip that I use in anyone who has a more than 20-year life expectancy.
Wow. So what is the expectancy with that, would you say?
It's a great question. Of one I will answer based on the science, because we've only been using it since 1997.
Correct.
In the laboratory, when we tested the plastic and metal balls, the laboratory machines we used predicted a 12 to 18-year life expectancy. And it turns out, in life, that's what it worked out to. So we happen to know the machines we're using to test are pretty accurate. In the machines we're using for the ceramic are looking at 35 to 50 years. Will it last? We don't know. But the machine testing
says it will.
Says it will.
It was accurate.
Yeah, absolutely right. If it was accurate one, it should be with the other. But we don't know sometimes what the body will do. But we've been using, interesting enough, and I did say we're using this since 1997, but in reality, this ball, this ceramic ball, we've been using this for 30 years.
Oh, okay. Going into,
it's been the cup.
Yeah.
In the cup, we've added it since 1997, and for public use, 2003. So we've been using ceramics for an extraordinarily long time. So
it's
like
a great approach.
It's a great approach. An alternative approach, which is respected, is to use a metal head and a metal bearing. And we've perfected that fairly well. There are some concerns about whether or not using metal on metal will shed some metal ions in the body. Very theoretical. We don't know yet. I still feel personally that the safest, what is called most inert, the safest bearing surface today, and the one that lasts the longest, is the ceramic on ceramic. So choosing the surgeon that chooses the correct product is extremely important.
Well, with all the back research on the titanium, et cetera, and everything on target, I mean, it seems that ceramic would be beneficial for most people. Is there any downside? Is there anyone who would say, hey, doc, you know, I heard about ceramic, I don't want to go that way?
No, there's no downside except the cost. It is a lot more expensive to have a ceramic hip replacement. The patient doesn't pay the cost. The hospital pays the cost. Some hospitals I know of put pressure on surgeons to not use ceramics because it's expensive. I don't want to mention these hospitals, but I will tell you that White Plains Hospital, and you know, it's a not-for-profit hospital, has no restrictions on the use of what implants we use. So it is completely left up to the surgeon with no pressure. So for us, we absorb the cost for the greater good of the patient. When would I not use a ceramic? An 85-year-old person comes to me. I can say that an 85-year-old with a metal on plastic hip, which is a great gold standard, will last 20 years. So to 105, it's not worth the extra, $5,000, $8,000, and you don't know what's in you. It's all a question of life expectancy. That's why I say if someone has a 15 to 20-year life expectancy, they get the ceramic with no questions asked.
And is there any limitation to the patient's ability to exercise, to go back to work? Say a 55-year-old who needs a hip replacement. Just tell me a little bit about that. Tell the audience about
It's a great story. I mean, we have in my office a testimonial from a sergeant detective in the town of Yonkers who did not want to retire. He could have taken a disability. He was at 15 years or so. And he had hip arthritis. We replaced him with a ceramic on ceramic. He has gone down. He's now a lieutenant.
Yes.
And he wrote a letter to the chairman of Stryker thanking him for the ceramic on ceramic technology because he wanted to continue being active in the police department. I've taken care of a lot of White Plains police people as well, who also return to their same active lifestyle as a police officer in White Plains or Yonkers, and I'm not afraid of this wearing out.
Gotcha.
So it's really...
It's not going to crack. It's not going to wear out.
Not going to crack.
It's the way to go.
We have tennis players, club champions, golf.
Yeah.
You know, Westchester's big golf.
Yeah.
I even have people who go to the library
okay.
and could read any book forever without any problem of it wearing out.
Isn't that great?
It's incredible.
That's a great invention. You know, Doctor, we want to move on just a little bit to talk about knees.
Sure.
Okay.
Sure, absolutely.
If you would, we have a few minutes for that.
I appreciate it.
So let's just go over. I know in your practice you do a lot of knee replacements, both partial and full. Right. So just when would you do a partial partial knee replacement, and when would you do a full knee replacement? Just a little overview on that.
Sure. We do a lot of knee replacements in our practice. The only reason we do more knee replacements than hips is because there's more knee disease in the population than hip disease.
Okay.
So we do an equal amount. Our practice, or myself, we really specialize in minimally invasive approaches to knee replacement surgery.
Okay.
The most minimally invasive is what we refer to as a partial knee resurfacing. Okay. Unlike a knee replacement where the whole bone and the whole joint is completely removed, if your arthritis is isolated to one area, I can do a minimally invasive partial knee. Now, the company that we use tells me that my practice, that we do number 4 in the country in volume in partial knee replacements.
Wow. That's big.
And so this is a pretty big country, and White Plains is a pretty big city.
Place. That's it.
And we do number 4 in the country in volume according to this company. I haven't called up every surgeon in the country, but I know we do a very high volume of partial knee resurfacing because we're very... People come to my office, I say, you have entered the den of a minimally invasive evangelist.
There you go.
Okay?
I love that.
And if you notice, this is a knee where you have your regular ligaments, these ropes.
Correct.
In a total knee replacements, all those ropes are ripped out, metal and plastic on both sides. What I do with a partial knee resurfacing, if the arthritis is restricted to one side, which is in 70% of patients, I can make a 2-inch incision, leave these ligaments completely intact, leave them there, leave this ligament alone. I resurface the end with essentially a computer-navigated burr, almost like something you would get at Sears, a router.
Okay.
Maybe the one at Sears is better.
Maybe that's a good check it out.
I think Sears moved from White Plains.
We'll
have to get it somewhere else.
Okay, cool.
And then we make a cut here and put a medical polyethylene here, and then we close a joint. This takes me on average less than 35 minutes to replace. Patients, my world record is a woman who is 86. I did both of her knees. She drove alone to my office at 2 weeks and 6 days.
That's phenomenal.
Unheard of in total knees.
Oh, my God.
So we now do 70% of my knee replacements are partial knees.
Okay. I have to ask you, because patients will come to my office with knee situations, and they'll say, you know, Doc, the orthopedic surgeon said I should have one knee done, not the other one, or should I have both done together? It's a fairly common question. That's why I just want to run that to you. If they wear out together, would it be best to usually get one or do the worst one first? Or
well, there's a couple of questions that I ask when they come in with arthritis in both knees. First, if I was to do one knee, will you still not be able to walk because the other knee is so painful? If that's the case, then I need to do both at the same time. Because I'm not doing anything for you by doing one.
Correct.
We also, some people say, well, the other one's eventually going to hurt the same. Why don't I get both done? And that's an obvious answer that no. One advantage to the partial knee resurfacings, you have two great advantages. One is, while in a regular total knee replacement, which many people do, and I feel many are done unnecessarily, I have to tell you straight, but I really feel that a majority of total knee replacements that are being offered should probably be partial knee resurfacings. And too much bone is taken out, and too many options are burned. But what happens is, the two great advantages, you lose no more than a third of a cup of blood in a partial knee resurfacing, while you'll lose 1 to 2 units of blood in a total knee. Yeah. So if you were to get both knees done, total knee replacement, you would certainly need community transfusions.
Yes.
You couldn't donate enough of your own blood before surgery for that.
Right.
In partial knees, I don't even ask the patients to donate any blood before either single or both at the same time.
Such a small amount
and
of
in
loss.
over 500 consecutive partial knee resurfacings, not a single patient has come close to require a transfusion.
Wow.
So when people need both with the partials, we have no problem.
Right.
Plus, if you notice, one other great advantage is by leaving the rest of the knee intact.
Right.
If this wears out in, let's say, 10 years, 15 years, we haven't burnt other options. 10 years from now, what if I told you we had a biologic replacement for a part of the knee? So I'll replace this with a biologic and leave the rest of the knee okay. So we don't burn as many bridges. And the life expectancy of a partial and a total knee are the same.
Right.
They fail at 1% a year. So if I did 100 today, 90 will be around in 10 years.
Right.
80 will be around in 20.
Wow.
And that's about
phenomenal.
the statistics.
That's
why we are big fans of the minimally invasive approach to this. We also do a minimally invasive approach to hips as well, but we've already covered hips, so we'll stay on the knees. But what's really minimally invasive, instead of putting this much metal into a knee, we're putting so much less.
Understand. So less recovery time, back to work sooner.
Oh, yes.
More options down the road if they're having more problems.
Every major study has shown that the type of activity a patient can go back to after a partial is a higher level of activity. In other words, they'll play tennis instead of doubles, maybe singles.
Now. That's terrific.
Yeah.
And, just as a final question, Doc, if you could just tell me, give the audience some advice. If they want to stay active as they're aging and they've had some knee problems, what would some advice be?
Well, I think it's the same thing that I would offer that you would offer your patients, your practice. That general wellness is absolutely the way to go. I can't underestimate how much total weight, nutrition, vitamins, supplements, so obvious. General weight loss. I kid around my patients. I've lost 5,000 pounds in my life. I gained 4,970 back, but I got... Now, let's take that's the obvious. The second thing is about joint health. It's unclear whether many supplements help, like the glucosamine and those things, and some do. We're not sure yet. But certainly weight and some strengthening exercises are critical to protect joints. And I'm a big fan of weight training for joints. And a daily walking program. I think if everyone in America walked a half hour a day, we would probably improve our health dramatically.
Great.
So staying active is important. And then taking care of the obvious. Your cardiac problems.
All the medical
Don't
problems.
be afraid to go to a doctor.
There you go. Go when you need. Dr. Kireshenbaum.
Go when you need.
I would love to continue, and maybe we'll get together again. I want to thank you for being my guest on the show tonight. It's been my pleasure. If you have any questions for Dr. Kireshenbaum or for myself, you can email us on our website, and we'd be more than happy to answer them. Until our next show, thank you and good night.
Thank you.